And today I would like to present the outcome of ongoing project about long-term care policies and the impact of long-term care policies in some countries in Central and Eastern Europe. So this is only one of the steps, because my entire project is also about linking the macro and micro levels, as we heard before. But here I would like to focus more on the macro level, but instead of going into details, I would like to tell you more about the processes. The objectives of my presentation is to evaluate and compare policy developments in two countries from this region, namely Poland and Czech Republic. And since this whole conference is about policy issues, I also would like to stress some policy options for those two countries. But as I said, I will not go into many details. Fortunately, we have some presentation about Poland and Czech Republic during this conference, so I really encourage you to participate in those presentations. But the structure of my presentation is as follows. Firstly, I would like to give some brief justification for choosing Poland and Czech Republic. Then I would like to tell you more about the background. And by the background I mean the role of informal care in those countries. This is very important because the impact of policies on informal care is the main criterion for my work and also for this presentation as well. So after that, I would like to move to, let's say, comparative work. But as I said before, I will not go into many details. I just would like to stress different processes that are being taken in those two countries. And lastly, I would like to, in the concluding part of my presentation, I would like to give some policy implications as well as some research perspectives. Okay, so this is only the structure of the presentation. So at the very beginning of my talk, I would like to invoke the title of the whole conference. The title is "Where Next for Long-Term Care Reform?" And by invoking this, I would like to say that Central and Eastern Europe is a nice place of study, because a lot of nice things, reforms will happen in the near future, because there are many blueprints for reforms, etc., etc. But in fact, in some countries, like in Czech Republic, the comprehensive reform happened a couple of years ago. So I think that this region fits well in this conference because of the dynamic situation. I have chosen Poland and Czech Republic because, in my opinion, and I have some data on this, those two countries represent quite different cases within the region. Because, as I said before, Czech Republic introduced quite comprehensive reform in 2006, 2007, whereas Poland is still looking for new solutions. So we have two different cases within the region, and that's why I thought that this is those two countries are good examples of cases for comparison. So let's move to the informal care, since I mentioned that this is quite important in this context. Here we can see some of the main determinants of informal care in Central and Eastern Europe, in Poland, and as well as in Czech Republic. One of the most important one is that we still observe a high supply of people who provide informal care. Why is that? Because relatively, countries from societies from Central and Eastern Europe are relatively young in comparison to Western countries. So the group of middle-aged people, mainly women, are quite big still. Of course, processes are quite dynamic, so that the situation will change in the near future. What also affects the high supply of informal carers is that we observe a considerably low female employment rate. So this of course, in microeconomic thinking, this affects the opportunity cost of care, etc., etc. And Poland actually has got one of the lowest female employment rate among the middle-aged people in European Union, whereas Czech Republic is close to the average of the European Union. We have also some other specificities of the high supply of informal carers. I don't want to go into details, but one of them is linked to the second distinguished here. I mean, we can observe a prevalence of co-residence, or as I call it, near co-residence between generations. Here we have some data from share. The question was asked. The question was answered by people who are 50 years and older, and we can observe here that among this group, about 16% of older people live with their elderly parents. This number is smaller in Czech Republic, but if we add also the other proxies for proximity, like for example living in the neighborhood, the picture changes very big, and will become very considerably. So we do observe phenomenon that affects informal care in those two countries. According to data, co-residence or new co-residence is much more important in Poland than in Czech Republic. Also, if we look at the survey data, we can see that in those two countries, especially in Poland again, we can observe a very strong public support for informal care. According to, for example, to Eurobarometer study, in Poland there is the highest rate of support for care provided by families. But still we don't know whether this effect could be linked to like cultural values. I mean that those traditional values shared by a majority of society, or it is caused by some economical structural factors, like for example this one. So we have to be very cautious when it comes to those preferences, because sometimes there could be a sign of no other options. But still, if we recall from data, we see that there is a strong public support for informal care, especially in Poland. Here we have some data from a very comprehensive study called Polish Senior, and we can see here the help for the dependent elderly in Poland. It is split here by people who live alone and people who do not live alone. And what is really obvious here is that the bulk of the help for the dependent elderly in Poland is provided by the members of the family, and the role of the social workers is very marginal, and it increases only when the older people live alone. This is closely linked to the eligibility criteria in social care system, but I will come back to it in a few minutes. So this is only the description of the role of informal care in one of the countries that I'm studying. Okay, So this was the background. Now let's move to the policies. And the first thing I would like to stress is that in Poland and in Czech Republic, there are no distinctive long-term care systems. We have just talked about those comprehensive systems, but still in our countries we cannot see such a integrated service system. Instead, we have some different welfare state systems, healthcare systems, social assistance, and in Poland we have also some schemes in pension system. I will also come back to it in a few minutes. So it is a good description that that those two systems are very fragmented, and the boundaries of long-term care policy are very blurred. In my presentation, I will focus more on the social care system because of these reforms in the Czech Republic. But it is very important to say something about the healthcare. In both countries, we have social insurance systems with a very almost universal coverage. But when it comes to long-term care, there are many differences between those two countries. And in Poland, there is a very restrictive eligibility criteria for services financed from social insurance. Because the Bartel scale is used, widely known Bartel scale. And the threshold has been set up on very low level, by a maximum of 40 points. So that means that people who are severally dependent on health, those people only are eligible for services which are provided, which are financed by social insurance. This threshold was changed in 2008 from it was changed from 60 points. The reason for this was, of course, just the reason they did it in order to limit the number of people who are covered by social healthcare insurance. What is also quite visible process in Polish healthcare system is nursing homes, because we are observing that process of closing down hospitals for chronic patients, and there are more. The number of nursing homes is quite rapidly increasing. The crucial difference between those two units is that in hospital wards, accommodation was free of charge, whereas nursing homes, there is a payment for accommodation in those units. So you can clearly see the increasing of the private involvement of private resources in public system by changing the threshold and by, for example, by creating new units. In contrast, in Czech Republic, long-term care hospitals, special units, they have persisted without any amendments. They were created in the late 70s. In the literature, it is said that the quality standards in those units are quite low, but they are free of charge, almost free of charge. So, of course, for the resources of private households, those differences matter a lot. Okay, so let's go to social care. Here you have only the number of beds in healthcare sector. Those are on my calculation. I compared those calculations with OECD data, and they differ a lot. sometimes also level things differently. And here we can see that the number of deaths in healthcare sector increased in Poland, decreased slightly in Czech Republic, but mainly due to the increase of the number of people aged, by the number of elderly people, not by the closing down the units. Okay, so let's move to the social care. As I said before, the reason why I have chosen those two countries is that in one country we had comprehensive reform. I call it a new paradigm, which was, this reform was introduced in 2007. And then one of the main elements of this reform was the introduction of universal care allowance. In Poland, in contrast, we haven't seen much reforms. There were many small minor changes, which were mainly connected to the new legislation about social insurance, social assistance in 2004. Okay, so the reform in the Czech Republic, I don't want to explain everything about this reform because it was quite comprehensive. The main thing here is that the care allowance was introduced. It was inspired by the widely known, widely discussed idea of consumer choice. So the people who are dependent on health, they were given allowance, money, and he or she can use this allowance according to their will. The reform distinguished 4 levels of dependency, and the amount of the care allowance depends only on her needs. This is granted regardless of income or family situation. What is quite crucial here is that the amount of this benefit is quite big, especially when we compare this amount to the average pension. In the last level, for the people who are totally dependent on health, it exceeds the average pension. This reform also introduced many other important things like quality criteria, registration of providers, etc., etc. But for the informal care is not so crucial, because what is quite important is that when we try to evaluate this reform, we can see that the recipients of care allowance predominantly opt for informal care. So most of them do not allocate this money to the registered providers. There is, of course, this idea of consumer choice, and according to data, it is very clear that people who get this allowance choose the informal care. This idea of misusing the car allowance was used by the government in 2011 when there was a big problem with deficit, and the amount of the allowance was decreased, but it was decreased only in the first 2 levels of dependency. And the main argument posed by government was that it is misused. People do not buy social services, so that we have to cut this benefit. So I think that the government is quite aware of the fact that most of the people in Czech Republic use this allowance for informal care. There is also quite important thing associated with reform in Czech Republic. This is the high demand for institutional care, because one of the underlying assumptions of this reform was to increase the role of community care. We all know these ideas. They are quite universal in Europe that we have to strengthen the care of the community, etc., etc. But the evaluation of this reform clearly shows that the high demand for institutional care is still untouched. Okay, but I don't want to go now into the details. Okay, so here we have the numbers about the utilization of different forms of care by recipients of care allowance. And I have chosen only people who are in the moment they need the most the care, because they are from the third and fourth level of dependence. And we see that, fortunately I don't have data for 2012, that most of the people opt for informal care and also for institutional care, which is still quite understandable if we take into account that we have a 4 level of dependence. But still, half of the people who got it, who got the allowance, opted for informal care rather than community care, for instance. Right? So
the way supposed to sum up with one community?
No.
What is the
Community care.
Oh, yes. Community care.
Yeah, community care is absent. Or this allowance could be also could be mixed. Part of the allowance could be used for informal care and part for community care, for instance. So there is something missing. Okay, this was the very short description of reform in Czech Republic and the impact on informal care. Now let's move to the long-term care policy in Poland. As I said before, we can observe in Poland very fragmented systems, distinct systems. Apart from healthcare and social care, we have also nursing benefit, which is granted for people who are no less than 75 years old. There are also exceptions, but this means that every person who is 75 and more is granted by some extra money. It is called, nominally, it is called nursing benefit, but in fact the level of this scheme is very low, and it is hardly used for buying care in the market. But the crucial thing is that it is regarded as a source of the additional income for the elderly, for the pensioners.
You really have to be 75.
Yes, that's right. All people who are 75 and more, and who are into pension system, they get it. Also, people who are not entitled to pension system, they have social assistance scheme, which is very similar to this one. So, but this is like a sign of universalism and these very marginal systems, especially when it comes to social care. Because in social care, the main idea, the main concept in social assistance in Poland is the concept of subsidiarity. And this means that the help for the elderly should be granted in the first place by the members of social informal networks, predominantly the closest family. So the eligibility criteria for the services in social care in Poland takes into account the family situation. So the entitlement to care is restricted only to those who could not receive support from their families, and in case of the community care, even if they live apart. So this is like one of the criteria of assessment for social care in Poland. The criteria for residential and community care are quite different, but I don't want to go down into details. One quite nice thing is that the amendment in 2004 introduced a new rule of paying for the social assistance homes for the elderly. I mean, this is nursing homes. This is nursing homes in social sector. Let's say, very simplified. And here we can see a graph according, and we can see that the purpose of the new rules of payment for social assistance homes, according to which a family is obliged to pay for the elderly when our elderly is not able to cover the cost. The idea was to limit the number of people on waiting list and the new resident was fulfilled. Because right after introducing this rule, according to which there is a family obligation for paying for care in the residential units, the number of people in the waiting list and also for the residents dropped quite dramatically. So we can say that there is a responsiveness of private households in their strategies. Okay, so while in Czech Republic we can say that dependency is part of the social rights because the allowance is granted regardless of income and family structure, in Poland we can see the increasing involvement of private resources. We can recall famous paper written by Jakob Hacker, privatizing welfare state without privatizing social risk without privatizing welfare state. And probably we have such a situation here in Poland because the involvement of private resources is bigger. Okay, this is quite nice table, but I don't want to now to talk about this. The only one thing which could be used for drawing any conclusion and also for policy implementation is that some pre-reform predictions concerning the usage of formal care have not been fulfilled. I mean, there was an idea before the reform in Czech Republic that there will be a creation of market of providers, mainly in the community care. And it is quite clear that this aim has not been achieved. Why? We can say that there are some supply side problems, and social service providers tend to say that, for example, the maximum prices introduce some rigidity in the system, etc., etc. But quite important thing is also to focus on demand side problems, mainly predominantly connected with informal care. So we can ask now: is a direct payment the best solution to achieve the aim of increasing the supply of home-based formal long-term care in such a circumstances when we have such a important role of informal care? But still, we have to keep in mind that the transition and the other processes like immigration, for instance, will change the situation quite. Actually, we don't know how, but somehow it will be changed because the co-residence levels. It is believed that they will change because in the rural areas people emigrate to Western countries, etc., etc. Okay. Policy perspectives. We don't have a time for it. As a chief of this session, I just would like to say now that we have to end now, and we can open the discussion. I just would like to say at the very end that we can also pose some questions that how research on Central and Eastern Europe could enrich our knowledge about understanding of long-term care. Of course, you can ask whether those countries will emulate a solution from the Western countries. But also, I think that this is a very good terrain for testing the links between long-term care reforms and informal care, because long-term care reforms are very likely to happen, but the determinant of informal care will be very strong in the future. So, in my opinion, Central and Eastern Europe is a very good area of study when it comes to this nexus, let's say. Okay, so thank you very much for your attention.